Thanks for staying tuned. You are watching Good Morning Nigeria on the network service of the NTA. Just before we bring in our panel of guests for our conversation on the improving primary health care in Nigeria, let's take this background report by Oyeyemi Ajayi.
Globally, the health system of a country is quite pivotal towards growth and development of its economy. Nigeria is not in any way different, with its vast population of over 240 million dwelling in urban and rural areas, as conceptualized by the Alma Ata Declaration of 1978, to which Nigeria is a signatory. Primary health care is a grassroots approach towards universal and equitable health care for all by providing accessible, preventable, curable and rehabilitative services. Subsequent leadership in the country have really prioritized development of the health sector, especially the creation and replication of the primary health centers in parts of the country where even the rural dwellers can access it, but the avalanche of challenges affecting the sector seem overwhelming. Poor health infrastructure, shortage of manpower and weak systems have contributed to poor utilization of the primary health centers. Worthy of note is that the primary health centers constitute 85% of the clinics and hospitals in the country, but only about 20% of these are functional, as 75% of them do not have minimum required equipment package, including essential medicines, persons protective equipment, amongst others, and this questions the seriousness applied in strengthening the primary health care centers. Experts say Nigeria needs radical structural reforms to build a functional and resilient primary health care system with federal support, while the states and local governments should prioritize and drive the process. As it is, primary health care in Nigeria has received little investment from the private sector over the years. This informed the federal government's plan to work with state governments and development partners to increase the number of primary healthcare centers from 8,300 to 17,600 nationwide in the next 4 years. Now, what more needs to be done to strengthen the primary healthcare nationwide? Also, what efforts are governments at all levels making in ensuring that every Nigerian, especially children and women, mostly the rural dwellers, have easy access to quality healthcare services? These are some questions guests on Good Morning Nigeria will be answering shortly.
Thank you, Oyeyemi Ajayi, for that backgrounder. Now joining us in the studio is Dr. Muyi Ayino, Executive Director, CEO, National Primary Healthcare Development Agency. You're welcome to Good Morning Nigeria.
Good morning.
And congratulations on your
Thank you very much. It is a pleasure to be here again.
We also have seated here in the studio Dr. Isis Akuma Egboja. He's a regular on Good Morning Nigeria. He's a public health specialist. You're welcome to Good Morning Nigeria as always. Good to see you.
Thank you very much. Good morning.
Okay, let's kickstart our conversation with Dr. Muyi Ayino. I mean, going by the report that you just listened to there, you discovered that the primary healthcare services in Nigeria is fraught with many challenges. What is your own assessment of the primary healthcare system in Nigeria, and what are some of these challenges?
Thank you very much. I think I will think about the challenges in a number of buckets. When we came in, what we met on ground was that there has been a substantial amount of investment in the primary healthcare system even before we got here. And like the report mentioned, successive governments have made efforts. And you see that in many different ways there. Most Nigerians can probably point to one primary health center that they know. The challenge, like was also mentioned, is that there are upwards of 30,000 PHCs around the country. Many of them do not necessarily meet the bar of what you will call a functional primary health center. What a fully functional primary health center really means is that it's got a decent infrastructure where Nigerians can walk in and access basic healthcare services safely, but also with dignity. So there's privacy, there's basic utilities and things like that. It's got the workforce that you need. They don't have to be advanced specialists, but you know, you have midwives, you have nurses, so that a pregnant woman can walk in and deliver a baby safely and, you know, attended to by competent, skilled birth attendants. It's got the commodities that you need and, you know, basically mechanisms to operate the facility. So what we found is that a substantial proportion of these facilities are not at that level. So that informed a big part of what we're focusing on as our strategy. I think the second issue that we found is that I think positively, on the positive side, is that the National Health Act of 2014 established something called the Basic Healthcare Provision Fund, which is a government intervention that ring fences a sum of money in perpetuity that goes to funding primary healthcare services. I think this is remarkable because before now, there was always issues of no money for PHC, no money for health services. Is it enough? No, but you know, it's a start. But more importantly, it is in perpetuity. It is guaranteed. And what that funding does is it goes from the Federal Ministry of Health, managed by the Ministerial Oversight Committee, chaired by the Honorable Coordinating Minister for Health and Social Welfare, Mohamed Ali Pate, through 4 gateways to the states. The gateways, the National Primary Healthcare Development Agency is a big one. The National Health Insurance Authority is a big one. But we also have the National Center for Disease Control and the National Emergency Transport System. Those are 4 gateways. The resources go to the state, and the states pass them on to the primary health centers. Okay. For our gateway, what we do is focus on making the facilities service ready, which means they have a sum of money that they get every quarter that helps them to run the facility. Everything from the lights, the utilities, some workforce, and whatever else they need. Again, if you have workforce, if you have equipment, if you have things and you don't have the resources to fuel your generator, you don't have resources to clean your environment, you know, that's a problem. And that's how it was before. So fortunately, that's in place, and we're thankful for that. However, what happened was, since 2019, when the Basic Healthcare Provision Fund actually kicked off, the lessons have been learned. We have a total of 8,306 PHCs as of today. It's gradually increased over time that receive this funding guaranteed every quarter. But that has come with its challenges in that the ability to oversee the effective utilization of the money has been suboptimal in some places. I think in certain states, the states are at different points, right, in their evolution. In certain states, you know, less so than others, but in some states, there have been a lot of issues and questions at that point for many different reasons. There are the human reasons, there are the structural reasons. For example, when you give resources to health facilities and you restrict by guideline, you know, very tightly what they can do with it. But what you are restricting them to do with it doesn't necessarily match what their needs are. It's very difficult for me to sit in an office in Abuja and dictate exactly what you are going to need next week in a facility in a rural Damaturu, you know, in Yobe, for example. So we found a lot of things, and we're trying to also address that. I think the third challenge is sort of on the programmatic side. So we have certain basic services, and we can speak about each of them and what we're doing about them, like routine immunization. Coverage is low. Well, it's better than it was. It went from 33% to about 15% to 57% over the last 3 years. But that's far from the 90% that the government targets. The side effect or the impact, the implication of that is we continue to have outbreaks of vaccine preventable diseases, which puts us in this cycle of, there's a measles outbreak, you have to respond. There's a diphtheria outbreak, you have to respond. There's a meningitis outbreak, you have to respond. There's a polio variant, vaccine, circulating variant of polio virus that is, you know, raging everywhere. You have to respond to them. You'll be irresponsible to not respond. But when you have limited bandwidth, you know, and you're getting dragged left, right, and center to respond to these outbreaks, then it sucks away the bandwidth that you actually need to invest in the routine systems that you need to build up to again prevent these outbreaks.
Yes, you've talked about the challenges, and issues and questions, and we all know that the primary healthcare is a crucial part of the healthcare system in Nigeria, and with more than 30,000, healthcare systems across the country, some not functional. You've talked about the challenges. Can you tell us, since you came on board, what you've been trying to do to change the narratives and make it better, especially in hard-to-reach areas? Because when we say primary health care, it goes deep into the locality itself. What are you doing? What is on your roadmap? What do you intend to do to change the narrative? Maybe by the time you leave office, you say that I have done something, I've changed how it used to be. What are you bringing in that is new?
Thank you very much. We were fortunate in that by the time we came in, we have a minister who's visionary, who understands the system and has articulated for the health sector broadly a blueprint that really focuses on a number of things. One is the delivery of efficient and high quality, equitable services across all tiers. One is really around the governance of the health system. Governance meaning having health institutions that are strong, but also that are accountable to the citizens. And then there's a pillar around unlocking value chains. And there's a third one, a fourth one, which is the health security, really speaking to some of the outbreaks that I spoke about. So it was easy for us to very quickly take that and, in the context of the Nigeria Health Sector Renewal Investment Program that President Bola Tinubu launched in December 12th, which articulated a number of very important goals that he would like as the president to deliver to Nigerians, and we have been mandated to prioritize. It's really reducing maternal mortality and infant mortality. It's really, increasing the coverage of immunization, ANC, and other critical services. It's really improving the investment in terms of the functionality of health facilities, among a number of other outcomes. So we took all of that with our knowledge of the sector and articulated our own strategy in the primary health care system over the next 2 to 3 years. And that, again, focuses on 3 main pillars. The overall objective is that ultimately, to your point, by the grace of God, when I live here, we're working hard to make sure that we can say that every Nigerian, wherever you are, whether you are rich or poor, whether you are in the north, south, Abuja, Sokoto, or my village, Egbe in Kogi, that you can walk into a health facility, primary health center, and receive the basic care that you need. There are 2 sides to that. That means you have to have facilities that can provide that services, that have what they need, but that you also don't suffer too much financial pain. So our sister agency, the National Health Insurance Authority, is also working hard to get as many vulnerable Nigerians enrolled in national health insurance, so that even if the service is available, you don't have to spend a lot out of pocket to do that. So perhaps the most visible pillar of our strategy is really cascading down what the minister has articulated to the primary health care center level to say we want to have PHC services, basic services, that are very equitable, again, whoever you are, wherever you are, that are high quality, at that level, but that are also trusted by people. So, meaning that it's one thing for you to provide a service, it's another thing for people to believe in it and understand that, you will give them what they promise. But that's part of the challenges that we've had, where you have a history of failing, on people's expectations for a long time. People stop to believe in you, and you see that in vaccine rejection, you see that in women not wanting to deliver in facilities and many different instances. So to achieve that, we're doing a number of things. One is we are improving the functionality, and I'll say a bit more about that, but also increasing the number of primary health centers across the country that are supported by the Basic Healthcare Provision Fund. So what that means is that we're taking the 8,300 that exist now that are receiving quarterly funds and making sure that, one, we look at their infrastructure to say, is it even a decent place that should be called a health facility that you expect people to go to? I challenge my staff and our development partner colleagues that, how many of you patronize the PHCs, that if you cannot go to the PHC near you to access services and you're asking Nigerians to go, there's some sort of hypocrisy in that, So I challenge myself, and if you, even my daughter, we've joked about that, to say you have to come here, this is where you're going to receive your health care. So things like that. To do that, we've started an assessment to even understand the baseline. So just before the Easter holidays, we had completed 24 states to even understand what is the state of these facilities and try to prioritize based on data where we make investments. Then we will complete the rest of the 13 states right after the Salah break, actually, just to allow people some respite to spend time with their families. The second thing that and then of course we're going to expand, like I said. So once you get them functional, we also want to double the number. The president has committed to that, my minister has committed to that, but we want to do that intelligently. So not just going to say you have to have a second facility in every ward, because we know that not all wards have the same level of needs. A primary health center in Ikoyi is not the same as a primary health center in rural areas in Sokoto, for example, in terms of their importance. So looking at disease burden, looking at existing access and demographics of the people, but also distance to existing facilities. We want to use that. So the assessment we're doing, we're also geolocating the facilities, geolocating other facilities, other access points that people have, just to try to make sure that there's equitable access.
Are you in any way collaborating with state government and local governments? Because, where you talked about, accessing, these facilities, and you find out that most of these facilities are in a place where it's highly very difficult for the communities for them to be able to access. And also you talked about the issue of beliefs and traditional, beliefs of the people, the community, and for them being anti, primary healthcare services. Are you also involving probably the local communities, the traditional rulers, in order to be able to make sure that this is actually getting to the local people, the community themselves?
So, absolutely, in terms of working with the states. The National Primary Healthcare Development Agency has a mandate to develop primary healthcare services in Nigeria. That is policy development and implication, guidelines, standards, workforce development, resource coordination and mobilization. But we actually do not own any health facility. So it's the states that own and operate the primary health centers, local governments and states. Now, so what that means is that for us to achieve our goals or be effective, we necessarily have to work with and through the states. So in fact, one of the, I don't think we're going to have time to go through all of it, but one of the tenets of our strategy is also strengthen the way we are engaging with the states. For example, when I say we want to increase the number of health facilities, we only have so much in our budget. Thankfully, we have a substantial amount of resources that has been set aside, but that can address a few, maybe 100 or 200, across the country that can be upgraded. But the states are also committed to this. Many of them have expressed to us the fact that they want to invest in primary health centers. So our role is also helping them organize it to say, look, if you already have one here, maybe you don't need another one right next to it. In fact, in your state, this is where you have a gap from an accessibility perspective to your point. That's one thing. The other thing is that the basic healthcare provision funds that I mentioned, it goes through the states. Okay. So we can define guidelines, we can advise on how to spend it, but the states have to spend it. They have to supervise the facilities. They have to monitor it. They have to manage it. So we're really, working with them around that in terms of what to do. You also talked about the communities. Absolutely. I spoke about trust earlier on. I think you can solve for the supply side. You can even solve for financial protection through health insurance. But if people fundamentally don't believe that what you're offering is for their good, that won't work. And what we have found in our communities is that You know, one thing that is common is that every community has a community gatekeeper system, whether in some places it's the pastors, in some places it's the imams, in some places it's the traditional leaders, in some places it's the mothers and grandparents that actually influence people, you know, in terms of their health-seeking behavior. So we are working with all of these stakeholders. Again, we've in conversations with a lot of civil society organizations who have experience, who are trusted by the communities, you know, to engage with our PHC system, to monitor it for us. When there's a problem, we're not always going to get it perfectly. When there's a problem, let them let us know, but let them co-own it with us. Let us work, but also engaging the communities. We have the village development committees and ward development committees that are also community members that are helping to manage and oversee the facilities as well. So we're using many different mechanisms. One of the things that we've also committed to, by the way, is transparency and accountability. And part of that is that as we're progressing on the things that we have promised, we're going to be sharing with Nigerians. My hope personally is to be able to come here and say, you know, these 10 facilities have just been added to the list of functional ones. If you go there, you can expect to receive these services. If you don't, call this number.
Okay.
And in fact, the minister did unveil a number, you know, one number. We're going to expand it, you know, as we start to, you know, grow the body of work.
Okay.
Yes, before I go to Dr. Abuja so that he can have his contribution, let's talk about the Basic Healthcare Provision Fund, which was established to, you know, improve primary healthcare system. You met it on ground. And how is it helping in ensuring that the healthcare system is lifted above ground?
It has had phenomenal impact. Like I said, perhaps the biggest challenge that plagued the primary healthcare system before now was just the lack of reliable, consistent funds. So you have facilities, you put health workers there, but they can't get the commodities that they need. They can't get transport to reach the communities to do outreaches. They cannot hire cleaners, or they cannot hire extra midwives when they need it because of volume and things like that. They want to go pick up vaccines because they don't have their own power or cold chain infrastructure. They need to go to a nearby facility or the local government to pick up vaccines. They don't have transportation. So the Basic Healthcare Provision Fund has been transformative in that regard, in that it gives them a base of resources that they can predict, that is reliable. Again, is it enough to cover all of the service readiness things? No. But what we're doing now also is doing some sort of actuarial analysis to see what would it actually cost, and starting to work through the sector-wide program that the minister is leading to say, how do you take the resources that government has put on the table and mobilize other resources from donors and partners, and hopefully from states, to increase the pie so that the facilities can get more. But it's one thing to get more, it's another thing to spend it well. So it's been very transformative in that now the facilities that are supported by Basic Healthcare Provision Fund actually have money on a consistent basis to do the things that they want to do.
Okay, thank you very much. Let's bring in Dr. Abuja into the conversation. You are into public health. I mean, you know the challenges, and you've been there for so many years. Where do you think we're getting it wrong? In assessing, in the community assessing these public health services, because most of the time, the operators, they'll complain of inability to assess the fund, from government and all that stuff. What exactly do you think is the major challenge here?
Okay, first let me correct something. I don't think that the word getting it wrong is quite appropriate. I think maybe you have not got there.
Okay.
And there are challenges. First of all, let me say that primary healthcare thrives on partnership and ownership. Like Dr. Aina already said, the original idea, I was a small youth corps when we started it in Nigeria. So I was part of it, so I know the history. The original idea we had in Nigeria at that time, in the 80s, was that the federal government, like he stated, was going to set up guidelines, policy, and so on and so forth. And they were going to physically build the primary health care centers around the country, around the 774 local governments. The states were supposed to equip them, furnish them. The local governments were supposed to man them, provide the staff to work there. Then the communities were supposed to have committees that were supposed to agree on ownership of each of these primary health care centers. So you can see that it is not only a one-level something. The federal government is doing its own, the state is supposed to do its own, the local government is supposed to do its own, then the community is supposed to do its own. Now, talking about partnership, for example, that we're talking about, if the federal government is providing guideline, policy, now funds too, the states are supposed to be equipping those health centers. The local government is supposed to be providing the staff for them. The community, for example, is also supposed to be actively involved and take ownership of whatever health facilities around them. For example, if they have a borehole and the borehole does not function, the community should be able to generate fund and repair the borehole. They don't have to wait until the local government comes and repairs the borehole, or wait until the state comes. And by the way, of the number of functional primary health care centers that Doctor just mentioned, 8,300, it's just a minute number of what we need. Generally, actually, in the country right now, we have about 35,514 primary health care centers. Of this,
how many are functioning?
That's what he just mentioned, 8,400. So you could see the shortfall already. Okay, of this, about 28,547 is public. That's about 82%. The rest is private. Okay, so now coming into this challenge, the word challenge is very important here. The partnership, to establish a good partnership between the federal, the state, the local government, and the communities is quite a challenge. You would agree with me that while some states cooperate very well, the immunization coverage that he just mentioned, about 50-something%. At this time in Nigeria, we've been on this thing since 1986. I mean, real drive for immunization since 1986. And 40-something years later, we're just having half of the coverage of the country. And why? Because we've not been able to get the routine immunization right. He mentioned it. Very key. There's no way you can have 90% coverage with these sporadic outreaches, responses to outbreaks and so on that we're doing. It is not entirely our fault. Sometimes when there's an outbreak of measles, for example, or polio, for example, there's a need for us to do a campaign, a reawakening, more or less.
A sensitization and awareness campaign.
Yes, but there should be a routine way of immunizing children and pregnant women. That is what is sustainable. And I'm very happy now that there are funds that are being channeled through the states, to the primary health care centers, through the local governments, that will make the primary health care centers more functional. If you take the 8,300 functional primary health care centers that he mentioned just now, against the 774 local governments, it comes to an average of about 10 per local government. And that is grossly inadequate. Why? Because if, for example, a local government has 15 wards, it means that out of the 15 wards, which is about the average, only 10 would have one primary health care center, which is not adequate, of course. Primary health care center, first of all, should be available. It should be accessible, and it should be affordable. He already mentioned the issue of insurance. That's another challenge that we have. Most people in Nigeria are not insured, and you know that. It is only the few in government services that are insured, and those in private organizations too. If you go to a typical Nigerian village and you ask how many people in this village are insured or have a health insurance, I will be very surprised if you find more than one. I'll be very surprised. And if you find many, those people were not originally living in that community. They probably retired and went there. Because we're not routinely insuring all our citizens. We've not got to that stage yet. And I'm very happy that the present minister is working on that now.
Okay.
The rejuvenation of, first of all, provision of funds and of insurance for everybody, every participant that has a health need is a very key approach. And I'm very happy to say that. Because that's one of the ways in which we can be sure that there is consistency. You asked him when he leaves office, what is it that he's going to beat his chest and say, this is what I left behind. That's one of the things that would lead to leaving something behind. Because when you have a coverage and you can and the service is available, the service is accessible, meaning that it is not too far from you, and it is affordable. Affordable in this case now means that you don't have to pay from your pocket. If I fall sick at a time when I don't have money, I can get help. That's what it means. And we are far from that at the moment. To be able to ensure 50% of Nigerian population will take quite some time. They are working on it now. The reawakening, the rejuvenation of the process is going on. But we should also understand that the population is quite large too. It is going to take quite some time to get and expanding. Yeah, for us to get to the level where we want. And by the way, when we talk of availability of health services, we mean health services that are of good quality, that are efficient and effective. Very important. He already mentioned how some people reject services or don't even care to go to health centers because they already have
the mentality that
an experience that when they go there, there's nothing. And it is true. You recall that in the 80s and early 90s, there was what we call revolving essential drug scheme.
Yeah.
Okay. Where is it now? That's part of the problem that he stated, inconsistency. It has disappeared.
It did. You know, talking about routine immunization and, you know, people going to primary health care, which is the first point of detecting any kind of disease you have before you are now referred to maybe the teaching hospital or the general hospital in town. And you say people have sort of lost confidence in the primary health care because when they go there, most of the time there are no doctors, there are no nurses, you know, on ground because most of them come from town. They don't stay in the locality, and there's been complaint of lack of accommodation, you know, assimilating into the community itself. And talking about immunization, also routine immunization. I remember when we were kids, once there's an immunization, we just go line up. We just go and line up, and then we are able to get our vaccination. I don't know what happened along the way that people don't believe in these things anymore and are sort of skeptical about it. How can we bring people back on board to embrace government's policies in the health sector?
Many reasons.
Okay.
Many reasons. Sometimes we blame the government for everything. I think we should blame ourselves too. You and I should be able to know that when we have a child, that child, upon birth, should be immunized that day with BCG, for example. And that the mother should continue to follow up with that immunization schedule until the child gets the last one, which is measles, at the age of 9 months. Now, if you go to his office and you look at the records of children who are immunized, you will find that the dropout rate is quite high. If you go to any health facility, even the functional ones now, and you look at the records of immunization, if you take 10, for example, mothers who are coming for immunization, you'll find that a good number of them don't come consistently and don't follow up until the child is 9 months and receive the measles vaccine. So the blame is on all the participants, not just the government alone. Like I mentioned before, primary healthcare will thrive well on partnership, on ownership. Everybody should think that it is my responsibility, it is my duty, not just a government duty. The members of the community should take it upon themselves to make sure that children within that community, for example, are immunized. Yes, we've had some nasty experiences in some years back about polio, for example, where because of some little issues, some people said they told all kinds of lies and people were scared and they stopped going for immunization. But I'm glad that that was rectified. That was overcome. And now we don't have that problem again. But the need for...
But we're having the problem still in the cancer vaccine.
I'm coming.
Yes.
I'm coming. He already mentioned it.
Yes.
And you know as well as I do that these vaccines are not free from heaven. They are paid for by somebody. They are paid for by somebody. In Nigeria, you don't pay for immunization when you go to the health centers. It is free. But somebody pays for it. And for us to sustain this, there should be a routine way of generating the money with which to buy the vaccines. And not just vaccines. Of the 8,300 functional health centers he is talking about, there are equipment there. If you get pregnant and you go to primary health care to deliver, there should be equipment with which to deliver you. Somebody should take responsibility for providing for them. Now, let me go back to the issue of communication and coordination, which is very key and lacking at the moment. The federal government should not be flogging the states to accept this responsibility. Neither should the states be flogging the local governments to accept this responsibility. Maybe the local governments might have some challenges convincing the communities to accept services. Maybe. But even then, it is easy because if you are living in that community, you know everybody, it is easy for you to know where resistance is coming from, for example. It is easy for a traditional ruler to know, for example, I have 7 villages in my domain. Of these 7, only 5 are actively taking their children for immunization, for example. What is happening to the other 2? So the traditional ruler should be able to reach out to that 2 and find out what is happening there. Is it lack of trust? Is it lack of awareness? Is it reluctance? Is it accessibility that I talk about, physical accessibility? Maybe the terrain is bad. What is it? And how can they be helped? When everybody is actively participating in this manner, and there's a problem, for example, at the community level, that problem, if it is not solved at that level because they don't have enough resources, can then be brought to the level of the local government. And if the local government is not able to solve it, can then be brought to the level of the state. And if the state is not able to solve it, the federal government, which is now giving money to the states, the other way around should happen. They should be the one now to come and ask, we have this need, please, we need money from you. Now it is they who are pushing the money down. Are you getting the problem? Yeah. It should be a demand-driven issue. And you cannot demand what you don't know. You cannot demand a right when you don't know that it is your right. By the way, health is a primary right of every citizen. So I want to emphasize on that partnership, ownership, participation, and collective bargain.
And accountability too.
When you are doing your part, I will be doing my part. He already talks about accountability and transparency. That's very key too. Because if you go to a health center where there are supposed to be a certain number of drugs available, and you don't find them, but the state has provided them, then there's an issue. You should be able to find out what happened to the drugs.
Yes.
When were they supplied? How were they used? Why did they run out of these drugs? And if there's a stock out, how long has there been a stock out? And how soon will there be a replenishment of the drugs?
Okay, thank you very much, Dr. Abuja, for your thoughts on these primary healthcare services. There, I want Dr. Muya, to respond to some of the issues that he raised. The issue of, having ownership at the community level, organizing them to own these primary healthcare centers. And also the issue of funding, I want to revisit it again because he touched on it, that this funding sometimes is difficult for you to be able to monitor how these funds are actually being utilized. Do you have a mechanism in place, to actually, measure, to assess whether these funds are being used for the right purpose which they are set for? And also, he talked about the issue of inadequate manpower. Right now we have this Japa syndrome. Especially in the health sector, many of the health officials have left the country. And how are you bridging the gap, of inadequate, health, personnel in these health centers?
Excellent. Thank you very much. I will speak to those and also, but want to, if you permit me, very quickly address or clarify a couple of other things that Dr. Abuja mentioned. I think one is the drug revolving funds. I think it would be not completely accurate to say it's totally dead. Many of the states actually do have functional drug management agencies. Again, some are better organized than others, but there is a policy in place, and many of them actually have drug management agencies that procure and distribute in a revolving way drugs to their facilities, secondary, tertiary, and in many instances, primary health centers. I think the part of the challenge is one, of course, the management of that generally can be improved, but also the sustainability of funding. I can't keep supplying you medicines if you don't have money to pay me, or you don't control the decision to actually buy from me, then I can't keep. So just to mention that. On the financial protection side, yes, I think too few Nigerians are currently covered, but one of the big priorities of the minister through the National Health Insurance Authority, like you have said, is to use that part of the resources of the basic healthcare provision funds that is going through the NHIA gateway to give insurance to the most vulnerable Nigerians. There are many ways people get insurance. There's private insurance, there's sort of employer provided, there's public organized, sector and informal sector. But the government is taking responsibility to say for the most vulnerable Nigerians who are at risk of disease but don't have the resources, we want to insure them, and you will see quite a bit there. Very quickly on the health worker bit that you spoke, because there are two connecting points that I want to make. Yes, in fact, we find that in the rural facilities especially, the ability to have the facilities work 24 hours is a challenge, because like you said, many of the health workers come from town to the villages and they have to go back home. Now, if our job is to save women, to deliver women safely, many women fall into labor at night. When the PHC is not open, that defeats the purpose. So they don't have that opportunity. So in fact, one of the things we're prioritizing in our primary healthcare transformations is, especially for those ones that are not in the cities, that don't have a lot of staff that can do enough shifts, we're putting residences, on-site accommodation for health workers. That's part of the standards that we have defined, and that's what we are contracting, that's what we're encouraging the states to do, and that's what even all of their partners, all of the other partners that are investing in the PHC services. We have an acute shortage of health workers globally, which has resulted in a lot of mobility. The primary health system is very hard hit. We depend on nurses, on midwives. They're all leaving to the Western countries just, to make their lives potentially to earn more income. So, but there are many things that, again, the government is doing to address that. This week, we kicked off a retraining of 120,000 frontline health workers. Frontline ranges from doctors in some places to midwives to nurses to community health workers. Again, depending on where you go, the pool of health workers that you have is different. And the idea is that it's one thing to be there, but it's one thing to also know what to do and be able to cater to the whole human being when they walk into your facilities. So we're doing quite a bit of that. But the minister is also leading an entire end-to-end human resources for health strategy, which we're really looking at increasing the production of health workers. I'm sure you have heard that there's been expansion in capacity of medical schools and nursing schools and things like that. Increasing their retention through, salaries is one bit of it. Public sector salaries will always, like I like to say, be within the framework of what government can pay. So it's not going to, there's always going to be room for people to make more. But beyond salaries, people who work in healthcare, who are attracted to be doctors, to be nurses, also have an altruistic bone in them to start with. So if you create the enabling environment for them to work, in our case, I said, if you have a facility that is nice and conducive, you have what you need to take care of your patients. If you're tired, you need to rest, there's accommodation for you to rest because you are stressed when you are not busy. We find that some of those things, actually motivate people to stay. The National Primary Healthcare Development Agency, even though we're not directly responsible for hiring staff in the health facilities, we have over 2,000 midwives that we have recruited and deployed to all of the states to supplement what the states are doing, and many more community health workers, and we're looking to even expand that, but in a way that is sustainable, because one of the things that has happened historically is that you do these interventions and then when you pull out or the money finishes, it just dies. So we are looking at a modality to engage with the states, talking about partnerships and collaboration so that it's easy to transition that to them. You spoke about the vaccinations and the issues with coverage and HPV vaccines and stuff. I think on the HPV, I would like to say that that's one of the successes that I would like to say we have recorded since we got here a few months ago. I think perhaps the first official activity I did was to introduce the human papilloma vaccine virus into the routine immunization system, where the First Lady was there graciously to help us launch it. Of course, we met with a lot of, negative campaign and things, because you have to put it in context, right? A lot of the vaccines that we have routinely given is to children. This is targeting early adolescent girls in an environment where there's a lot of conspiracy theories around that. So we anticipated it and we jumped on it, frankly. And I'd like to say that as of last week when I checked, we are in the first phase, 16 states where it has been introduced. We have vaccinated 4.9 million young girls, which is pretty close to the target that we set based on the analysis of how many people need it. It's now routine, so if you go to the primary health centers in those 16 states, you can get it. In May, late May, we are introducing in all of the other states, and what we're doing now is the sensitization and learning from that experience as well, trying to do an even better job. For the other vaccines, we find that, there are many unvaccinated people, children, there are many under-vaccinated because of high dropout rates that he's saying. And what we are doing about that is to say, look, these people are not spirits. They exist in communities. And the data has shown that when you really look at who are the people that are missing information, that are not getting vaccinated or that are not completing their vaccination, they're clustered in communities. So we have done an analysis and identified 100 local governments across the country that we call zero-dose local governments, where zero-dose children are very many, which are children that have not been vaccinated. When you find a household where a child has never been vaccinated, that's also the household where the elder sibling is incompletely vaccinated, you know. So we have rolled out, one of the things that we did once we came in to address that is to say, look, rather than all these high-level campaigns and you continue to reach the same set of children and continually miss the same set of children, why don't you go to these zero-dose communities and identify the children? There are people, list them, who are they, who's their mother, what are their reasons, and one by one start to resolve the bottlenecks. For some of them it's because nobody has told them. For some of them it's because they don't have access. For some of them it's because they have some beliefs.
Do you have adequate personnel to do all that?
So we're not doing that alone. We're doing that with the states. We're doing that with a lot of our development partners, WHO, UNICEF, many other organizations that I will not necessarily mention here have been very involved in that. We're doing that for some of the outbreaks. We're doing that for routine immunization, actually. In fact, there's a big catch-up campaign. This chief executive officer of Gavi will be here today, actually, for the next couple of days. And one of the conversations we will be having is around that big catch-up to say, okay, if we want to close this gap, we need a big stock of vaccines. These things are costly. Even though it's free to the end user at the facility, somebody is paying. The government is paying a lot, but we are also getting a lot of help from our development partners, primarily Gavi, from a procurement of the vaccine perspective. So it has implications for them, and they need to know that, can you help us by making provision, excuse me, for us to do all of this. You spoke about accountability for the funding. One of the gaps is in fact that, and again it comes from multiple reasons. I think it's not always people's fault. Sometimes it's systemic, sometimes it's structural, sometimes it's individual bad behaviors. But what we are doing, last week actually, on Thursday, March 28th, the Ministerial Oversight Committee for Basic Healthcare Provision Fund met, and you might have seen in the news, and approved the disbursement of 25.8 billion naira, because the MOC had withheld funds for a while to try to put in place mechanisms to better utilize the resources. So we're doing a number of changes to the program. Okay. There are fiduciary changes, there are programmatic changes that really will result in a revised basic healthcare provision fund, which we are calling BHCPF 2.0, which will kick off in January. Some of the short-term interventions, immediate interventions are one. We have worked with the states, every state, to develop a state-specific remediation plan. The Auditor General did an audit of the program and identified issues. We also have engaged with the states and identified issues. So each state has a set of activities addressing their own problems. So you are only going to get your part of this money if you are implemented the changes that you need. You need to have a dedicated account. You need to refund some amount. You need to do this. You need to do that. But also, some of those will take a bit longer. So we are putting that into accountability. But you see, some staff are paid for by this program. So we can't withhold money till everything is fixed before you pay that. In addition, we're hiring and deploying social accountability officers, which are independent from government, which will be our eyes and our ears on the ground, which basically will check the performance. So it's one thing for the health facilities to report that this is what we have done. It's another thing for that to actually be true, you know? So we are getting independent verifiers.
Like the EFCC,
social account. Well, that's even another layer. I'll get to that. But actually hiring officers to go to the facilities a turn by turn to check, verify information, pending the longer term changes, and report to us where there are issues. We are working with the anti-corruption institutions, ICPC, EFCC, to say, guide us somewhat as we're designing these programs to minimize the risk of misuse of resources, but also working with us that when there is a report or a suspicion, they come in to help investigate and take action. That serves as a deterrent, but it also protects the resources in a substantial way. The other thing we're doing many things. The other thing is civil society.
We'll get to talk about them. We'll get to we'll actually have to take a break now. When we return, the conversation continues. Don't go away. You're welcome back, and this is still Good Morning Nigeria, and our guests are seated here in the studio. Dr. Aina, you were talking about accountability, bringing in the anti-corruption agencies to ensure that, you know, the money is not wasted and nobody steals money from the funds that comes into the primary health care. How are you going to work in conjunction with them to get results?
There are really two things that we're talking with them about. These conversations are led, of course, by the minister. It's one, they're part of the conversations around how much money is going to where, you know, when does it go, and all that. The second thing is, you know, what are some of the measures that we need to put in place to be deterrents, but also to be able to detect when there are misuse of funds. They also have a footprint, you know, is to say, sometimes when there is a suspicion, they will be alerted and they would also investigate on our behalf, and they have the mandate. If somebody misbehaves somewhere, National Primary Healthcare Development Agency does not have a mandate to take action against that. So they are the ones that have the mandate. So it's easier if they are already prepared, if they are already primed for that. I think the hope is that we don't have to get to that point too often. The hope is that people being aware that is being in place will be a deterrent as well, and motivate people to do the right thing a bit more. But beyond that, for the accountability around the money as well, is that between now and September, we want to put in place, or we are already working actually, to put in place tech-enabled visibility platform so that you can see live the money that goes from the ministry to the primary healthcare agency, from primary agency to state agencies, where the money is, how much is going to each facility. And ultimately, we also want to see what they are spending it on. So we want to minimize cash transactions and have electronic transactions to the extent that is possible. It will not always be possible, as you know, given the infrastructure that we have. But in many places, it is possible. I think we exaggerate the limitations of technology because it helps that the lack of transparency, you know, is desired. So I think we can do a lot. We're going to work with telecoms firms. We're going to work with the states to do that.
Yeah. We'll come to you, pause here a little, and then we'll bring in Dr. Abuja into the conversation. You know, you are a public health specialist and passionate about how the primary health care functions. You know, you talked about technology, uses of technology in ensuring that people at that level are able to get, you know, access healthcare for all. We're talking about maternal mortality. We talked about an ever-growing population in Nigeria. And the Dr. Aina also said at times women go into labor in the night. When they get there, the doctors or nurses are not there. But what about the local midwives? How can they be absorbed into the system itself to help? Because they are residents, they live there. You know, how can they be brought on board to ensure that we do not lose our children to maybe not having a doctor or a nurse around, because they are also efficient. They are part of the system too, don't you think?
Yeah. Okay. If you've been following what the Federal Ministry of Health has done in the last few years,
yes.
I'm coming to the last part of your question before going to the first one.
Yes, the scheme.
Yes, one of the things that they did was this midwife revolving scheme.
Yes.
I'm happy that I was one of those who was part of the initial discussion on that issue. What was happening was, we found in Africa, for example, Nigeria was one of the countries with the highest maternal mortality, also infant mortality. In the 80s, our maternal mortality rate was about 800 and a little above per 100,000 births in Nigeria. 800. Presently, it's 576. So you can see that's a drop. But still, 576 women dying in birth-related cases out of 100,000 women is a lot of numbers. So we're still far from the target that we would need to get to. The African average is 545. The global average right now is 223. So if the global maternal mortality rate is 223, the African average is 545, and Nigeria is 576. That tells you that we have a lot of work to do. In fact, at some point, Nigeria, Sierra Leone, and Sudan had the highest maternal mortality and also infant mortality. So there's a lot of work that still needs to be done. Now, the whole issue of services, participation, and so on. Like I said before, one of the encouragements that I have. Now let's go back before I forget to your other question.
Yes.
The coverage, the immunization coverage. That's what we're talking about, for example, or even the general services coverage. In a way, one is encouraged that it is not dropping; it is increasing. And I mentioned before that at the moment, with the leadership of the Minister of Health,
yes,
at the federal level at the moment, we are encouraged that there is this new rejuvenation, this new spirit. We can get it done. He already mentioned it.
yes.
The minister is pushing from all sides. He's using all his connections that he has to make sure funds are coming in, not just only from within the country,
But from partners.
from partners also, which is very key. Like I said before, nothing is free. The equipments are not free. The vaccines are not free. The drugs are not free. And even the services are not free. The health workers that are being recruited by the local governments are supposed to be paid. And this is why I am consistently hammering on this issue of coordination. If the federal government is doing everything, he is doing everything as the chief of National Primary Healthcare Development Agency, but the states are not equally responding, or the local governments are also not equally responding, then we still have problem. If you look at state budgets, what goes to primary healthcare is nearly zero. And let me mention here, if the federal government is constructing primary health care, what prevents states from doing the same? In fact, even local governments, why should the local governments provide only staff? What prevents them from also building? They say the more meat you add to the soup, the greater the flavor of the gravy.
Yes.
Isn't it?
Yeah.
So why is it that it is only at the federal level that there is this push? We have to get this done.
So what do you think should be done? At least to get the commitments of the state?
Exactly.
And
you asked him this question and he responded very well. See, the states don't have to wait until somebody tells them. Like I said, this issue should be a demand-driven approach. If the community knows its needs, nobody should wait for them to cry. They should be able to say, look, we are a council ward here. We don't have any primary health care center. The nearest one is 10 kilometers away from us. When a woman gets forced in labor at night, we cannot get her there. Then that cry would be able to go to the local government. If the local government cannot do anything, it will go to the state. If the state do something and it is not enough, that's when it should come. And they will say, okay, now we know you are working. You have 8,300 functional health centers at the moment. But in my state, we only have so number. We need more. Now, let me come back to budget. I've been following up health budget over the last few years. Do you know there was a time the national health budget was less than 3%? Some years ago, 4%. Recently, about 7%. Even when in budget it is about 10, 11%, the actual disbursement of that money is a totally different game. It doesn't get to that much. Sometimes it is a constraint that is reasonable. Reasonable in the sense that if there are no funds, you cannot disburse nothing. There have to be funds. So we cannot blame the government for that. They can only use what they have. And again, that's where the issue of partnership comes in. And this is where the issue of ownership comes in. If the states also are taking responsibility and they're also budgeting, whatever is coming from the federal is adding to the states. The money he's talking about that is being pushed to the states. It should be an addition. It shouldn't be the starting point. And whatever the states are pushing to the local government should be an addition. But then, here again, we have a political problem. Many states don't even allow their local governments to function. In the last 2 weeks, I was so glad, profoundly glad to hear that Benue State, for example, the governor says, I am going to give autonomy to the local governments.
Yes.
Excellent. Now, if Dr. Ina goes to Benue, for example, and he finds that primary healthcare centers are not functioning, he knows where to go to next. He can go to the local governments and say, you have money. We are providing you with all the support. Where is your own contribution? But right now, he cannot confidently go to many states and say that because the local governments have no money. As a matter of fact, if you go to the health department of many local governments and you enter their rooms, you wonder the last time somebody sat on certain chairs there.
It's like a dispensary.
That's true. That's true. Okay.
So the mobilization of funds is very key. We need to mobilize funds at all levels.
Okay, thank you very much, Dr. Abuja. We need to mobilize fund at all levels, and also the demand-driven approach that you talked about, which I want Dr. Aino to also speak on that. The need to mobilize fund at all levels is very vital here. It's very germane because reports say the health fund is funded through 3 main sources, including the annual grant from the federal government of Nigeria, equivalent at least 1% of the consolidated revenue fund. So how can this fund be increased to at least 2 or more? Because from what he said, of course, the health sector needs more funding.
Thank you. Good question. I think health sector needs more money, but so do education sector, security.
Every sector
needs a lot more money. I run a small agency in the scheme of things, so I understand what competing priorities actually look like. To be fair, I think that we continue to advocate for more money. I think this government, the President Tinubu government, has actually prioritized health very tangibly, and you can see that in concrete terms. The health budget this year is unprecedented. I can tell you that for my agency, because of some of the priorities that the president has articulated, the budget is multiple folds of what it was hitherto. Now, given the changes in the valuation of the currency, it may ameliorate some of that, but the truth is that our budget is in Naira, and it's a lot more than it used to be. But that's also the same for the Ministry of Health, that's the same for many of our other agencies. So I think while there are opportunities, and the minister again is taking that head on to find ways to increase what is ring fenced. For that, I think there are also other things we're looking at. A lot of donors who were spending money in an uncoordinated way before now. There's a lot of donor resources. The amount of donor money that comes to Nigeria for health, if you know it, you will actually be shocked. It's a big proportion of what the government is spending. But you don't see maximum benefit for that because it was before now poorly coordinated. So the minister is leading a sector-wide approach, which means some sort of transparency around who is doing what where, what resources are coming into the country for health, and how are they contributing to what we're doing, so that we're minimizing duplication, we're minimizing wastage, and we're already finding the benefit of that. Many of these things that take primary health center infrastructure upgrades, for example. Apart from what we have in our budget or what the Ministry of Health has, a lot of National Assembly members have constituency projects. We're trying to engage them to say, you know, these are the standards, these are the expectations. By the way, you don't need to build a new one because it's in your village, there's already one there. Can you focus on upgrading the one that is there? Or the building is there, can you focus on the workforce and the equipment instead, or helping them to coordinate that? The private sector does a lot of ad hoc engagement at primary health center level. So we are now working with the Private Sector Health Alliance to say, look, how do you coordinate this, to plan, to say where are there the biggest gaps for the private sector to adopt a facility, you know, and make sure it works. And then a lot of our development partners also have resources. Many times it's not to build facilities, but somebody says, I want to power facilities because I'm doing green energy. We are able to help them say, okay, these are the way you can get the most value for solarizations. Some say, I'm into wash, I want to do toilets and water supply. We say, okay, we look at the facilities. This is the beauty of the assessment that we're doing, to say, okay, this one has everything except reliable water supply or wash facilities, so you should go to these ones within the framework of the money that you have, because many times people have money that are targeted towards certain geographies or certain conditions. That's okay, but we help you coordinate all of that. So what the sector-wide approach is doing is making sure that, one, the resources that we have now is getting us a lot further. We're able to buy a lot more health for the money that we have. And that is already getting the attention of a lot more donors. We're getting pulled into conversations to say, we like what you're doing. You know, the minister is always, you know, that he said a lot about the coordinating minister being able to attract a lot of additional resources, is because the donors see what he's doing and they're attracted by it, and they say, we like this transparency, we like where this is going, we want to put more money. And we're seeing that the money is coming in. It's not going to be sustainable. Ultimately, you know, we're going to have to use domestic financing to sustain a lot of this, but at least in the period to bridge the gap, I think we're seeing a lot of.
Now, I want to ask, because of our time now, the National Health Insurance, you know, authority, how are you actually getting it across to the people in the local communities? Because from what he said, and from our experience also, many of them don't even understand what insurance is all about. And also, this insurance, does it cover the treatment of cancer and all? Because when you get there, they will say, your insurance does not cover this, doesn't cover this. What does it actually cover for the people?
Okay, so there are two questions in there. I'm hoping, and I would encourage you to also invite the DG of the National Health Insurance Authority to come and speak for himself, because I'm aware that, similar to us, there are a lot of changes that they are making to the way they are using the basic healthcare provision funds, but also the way they are organizing the health insurance landscape. There are multiple tiers of health insurance. For the primary healthcare level, we have a service package that is included. You cannot include everything. There's also the secondary level, on the tertiary level, but also giving the cadre of workers that we have at that level. That's not where you want to do brain surgery or remove cancer tumors, but simple things like screening, with non-communicable diseases. So we focus on maternal and child health, we focus on immunization, we focus on malaria, TB, HIV, those things that are the top killers of Nigerians in terms of health promotion, in terms of prevention, in terms of testing, and diagnostics and treatment, where it is simple medications or simple interventions at that level. Where you have more advanced needs, even for obstetrics cases, for women who are delivering, if you need surgery, we will typically refer you to what we call a CMON, Comprehensive Emergency Obstetric Centers, which is typically secondary facilities. So the vulnerable group fund, the VGF, that the National Health Insurance Authority is managing, what they are trying to do is work through the state health insurance agencies. Every state has a state health insurance agency to change the way they are using the money so that they can reach more people. Simple things like that, you get paid based on the number of people you actually enroll rather than the number of people you want to enroll, or you get a fixed amount. That in the hopes that we will change, their orientation, and many of them will work to get a lot more. We're also harmonizing what the basic health insurance covers and what the primary health facilities cover. We're also harmonizing with we're having to work very closely with them, as you will sense already. We're also harmonizing that when we have a facility that we have invested in that is service ready, those are the same set of primary health centers that insured persons are referred to. In many instances, you find that MPHD is investing in this set of facilities, NHIA is referring.
In 30 seconds, Dr. Aino,
yes.
What should we expect from your agency in the next, let's say, 1 to 2 years? Where do we expect to see your agency?
I think in the next 1 to 2 years, Nigerians should expect to begin to see increased number of accessible, high quality, accountable, and trusted primary health centers that we will communicate, that people will verify, and they can give us feedback based on their experience for us to continue to improve.
So you are putting feedback mechanism. All right, good.
Dr. Muyi Aina, Executive Director, CEO, National Primary Healthcare Development Agency. Thank you so much for your insight and contribution to this conversation. I'm sure you're going to come back to talk more maybe after some time, and let's see how far you've gone with your roadmap and what you'll be doing for the primary healthcare. I would love to have you come back to talk about it. Thanks so much for coming. Good morning, Nigeria.
Thank you very
Dr.
much.
Isaac Akuma Abuja, Public Health Specialist. As usual, it's been a pleasure having you.
My pleasure too.
And that's Good Morning Nigeria for today. Thanks so much for joining us. I am Jummai Yusuf.
And I am Ademola Ade. Do have a pleasant day ahead. Good morning, Nigeria, Thursday. Thank you.